Hello and good morning. I'm Nancy Sweitzer from Washington University in St. Louis, and it's my pleasure today to interview the principal investigator of the Summit trial announced this morning, Dr. Milton Packer. Welcome, Dr. Packer.
Oh, Nancy, Milton is the right way to, we've been friends for a long time. Yes.
So Milton, please share with us the top-line results of Summit.
So the whole concept of Summit is the concept that heart failure with preserved ejection fraction is really a disease that is linked to obesity. And it drives the disease process probably because of visceral adiposity that causes an inflammatory state and promotes sodium retention, and that leads to HFpEF, heart failure with preserved ejection fraction. So you would think that drugs that reduce weight, cause weight loss in patients with obesity might have a positive effect on the disease. Up to now, we've had data with semaglutide, the GLP-1 receptor agonist, showing improvement in health status, exercise tolerance, but we really haven't had solid data on whether these drugs can actually impact the clinical trajectory of the disease, can impact outcomes, can impact heart failure events. So Summit was a trial of 731 patients with obesity-related HFpEF, did not have natriuretic peptide criteria, but instead we enriched the population for people with very significant symptoms, exercise intolerance, high sensitivity CRP, chronic kidney disease, so that we would have a lot of events. And patients were randomized 1-to-1 to either placebo or tirzepatide, up to 15 milligrams subcutaneously weekly, and followed for an average of 2 years, up to 3 years. And a primary endpoint that was unique to this trial was cardiovascular death and worsening heart failure events. And we put most of our statistical weight on that analysis. The Summit trial found that tirzepatide, a GLP-1 GIP receptor agonist, not only reduced weight, we're not surprised, not only improved exercise tolerance and health status, we're not surprised, reduced inflammation, we're not surprised, but it produced a 38% reduction in the composite of cardiovascular death and worsening heart failure events. And we looked closely at the worsening heart failure events, and we focused on the ones that were really meaningful, the ones causing hospitalization or the need for urgent IV diuretic therapy, and that's where tirzepatide had the most marked effect, 50-60% reduction in risk. So a really nice result, and lines up so well with the trials with semaglutide. The two programs, when you put them side by side, are very reinforcing of each other, and really give us enormous comfort about the potential role of these drugs in the treatment of HFpEF, because most people with HFpEF also have obesity.
Certainly in the United States and growing globally.
Yes.
As you know, obese patients have been excluded from many HFpEF trials. So talk to me about, how you think your trial has shown that this is real HFpEF.
So what a wonderful question. Yes. So one of the great challenges physicians have is, how do you make the diagnosis of HFpEF in clinical practice in the community? How does a primary care physician make the diagnosis of HFpEF? Because most patients with HFpEF and obesity are seen in primary care.
Right.
And so how do they do that? And you say, well, I'll measure natriuretic peptides.
Right.
Well, no, you can't do that because they are low.
Yes.
Even though their filling pressures are high, their natriuretic peptides are low. You can't go by a low ejection fraction because their ejection fractions are normal. You can't go by volumes. You can't go by strain measurements. You might look at left atrial size, but a lot of people will say, well, that tracks with weight, and how do you know? So the one thing that we have gotten really excited about is Barry Borlaug's HFpEF ABA score, the one he published recently in Nature Medicine. It relies on weight, it relies on atrial fibrillation, and it relies on age. And if you put those three together, that's what ABA stands for, age, body weight, and atrial fibrillation. He has a probability scale, and he has validated that with invasive measurements. When we have looked at this probability scale, it was incredibly predictive of heart failure events, incredibly predictive, and our average probability score in this trial was exceeded 80%. So we're very confident because also half the patients had a heart failure event before randomization. So we were very comfortable we were studying HFpEF, but for this to be translated into clinical practice, there has to be a really enormous awareness, because when patients come in who have obesity and are shortness of breath on exertion, HFpEF has to be part of the conversation.
Right. I agree with you completely, but it is really a challenge in clinical medicine to confidently make this diagnosis. So let me ask you, so tirzepatide is unique in that it has the GIP agonism as well. How important do you think that is in this, can we use semaglutide based on step HFpEF, or do we really need to use one of the agents that blocks GIP or agonizes GIP as well?
Well, what we're really curious of is, what does GIP receptor agonism do? Mm-hmm. And what it can do is it can add to the reduction in adipocyte inflammation. It can do that, and that accounts for why when you add GIP receptor agonism, you get a greater weight loss than with a GLP-1 receptor agonism alone. If you really want to know the answer to the question, we need to do a head-to-head trial, and that would be enormously fun and enormously educational. But there is such a trial which is in progress, which is reporting out next year. It's not in HFpEF, but it's a cardiovascular outcomes trial. So with a little bit of patience, I'll hold the question until next year.
Great. So, a concern with these agents is that it's not entirely fat loss. There's lean muscle loss as well. Yes. In these patients. What insights do you have on that issue for us when we're worrying about our frail patients in particular, or sarcopenic patients?
And I think that's a very important question. And so one of the things that was sort of interesting was the fact that we had this very large effect on KCCQ, which is health status, and then we had an 18-meter difference in 6-minute walk, which improved. You might say, well, that gives you assurance that the skeletal muscle loss was not a major factor. Well, one question that should be asked is, if there weren't skeletal muscle loss, would the improvement in 6-minute walk have been greater? Mm-hmm. And we don't know. Right. But it's a real effect. What we're hoping is that with the mitigation of exertional dyspnea, patients who lose weight will be able to mobilize themselves and exercise, and that will mitigate the skeletal muscle loss. But we don't know that, and we did not measure that in Summit.
Okay. And did you do measurements of body composition in this study?
So we measured cardiac magnetic resonance imaging, and we focused on two things. We focused on left ventricular mass, and we focused on visceral fat around the heart. So CMR is great for studying that.
Yes.
And patients with obesity and HFpEF have incredible amounts of visceral fat around the heart.
Yeah. Well, and you can probably get pectoralis muscle mass too from that, which has been shown, at least in the VAD population, to correlate with outcomes.
That's a great idea, and I'm taking it home.
That's fine. So you're imaging all of the chest,
yes,
not just the heart.
Exactly. Yes.
Well, Milton, we could talk for hours. There's so much interesting stuff. I want to just close by saying that the science that we're about to see around this new therapeutic mechanism is so exciting. And you are to be celebrated for starting this off in such an amazing way. Thank you so much.
Thank you so much, Nancy. It's
My
great.
pleasure.
Thank you.